All right, so unlike my last talk, this one actually is very appropriate for what we're doing right now. These are my disclosures. I do work with a startup IVUS company. So why is IVUS needed? Obviously you're going to hear a lot of different opinions about this too, and there's plenty of operators out there who say that they don't need IVUS in order to be able to do their interventions. But the guidelines have expanded the indications and the number of endovascular interventions where it would be appropriate to use these types of technologies to guide your therapy. And the problem is, despite our best efforts, the number of amputations continue to increase. And while we're doing more procedures, are we doing good procedures? And so I hope you can appreciate that angiography is not enough. Some people still feel that a good angiogram is going to give them all the information they need. But what's going on within this vessel? How big is that vessel? What's the pathology that's there? And even vessels that look normal, you're just seeing a luminogram. You're not actually seeing what's within the wall or what the plaque burden is or where that plaque is located. So, what's the characteristics of this lesion? Is there a dissection there? Is there soft plaque or eccentric calcium, which may not be visible in that one view that you have? Is there a clot? Or is this, obviously if there's a stent, you'll be able to see the stent, but how much in-stent restenosis is there? And what you think here looks like a minor stenosis, because you're again seeing just a luminogram, this is just a tiny portion of the actual true vessel. In reality, there's a 75% stenosis there too, of this fibrofatty plaque, heterogeneous plaque, and our wire is intraluminal. So if you look at the differences in between IVUS versus angiography when it comes to characterizing plaque itself too, you can see that IVUS across the board gives you a lot of information here too. The only thing that it's not going to give you great information on is flow, and I think angiography really tells you that best. But you can see in all these other points here too, whether it be lesion location, eccentricity, where your wire is located, if there's thrombus there, what the plaque burden is, and what it looks like, IVUS is going to tell you all that information. Unfortunately, angiography really can't do that. So why doesn't everyone use it? I've been harping that this is something that we should be doing. In the coronary world, we were well versed in using this technology, but despite that, it had a very low penetrance, only around 10%. And recently, it's actually up over 25% of coronary intervention. So the numbers are actually rising because there's a lot of level 1 evidence saying that if you don't do it, your outcomes are much worse. But part of the problem too is that a lot of the trainees coming out, people who are learning to do this, and also people that are in the field, really do not feel comfortable doing interpretation of IVUS images on their own, even coming out of fellowship in the modern era. So that's a big problem. And so if you think that's an issue with coronary operators, imagine what happens in the periphery where the training pathways are a little bit more heterogeneous. And so you can see that in general, still penetrance of IVUS is still relatively low across all the procedures done. And I think the vast majority of IVUS utilization, partly because of the reimbursement strategy, is still being done in the OBL ASC space, where it is reimbursed and physicians are incentivized to use it. And you can see that in the hospital, it's actually significantly less. And hopefully this is something that will change, because it is currently reimbursed at all sites of service, just somewhat differentially. So, I'm not going to talk about venous stuff because that's something that's a whole different ballgame. But there's obviously a significant need to improve education and training, and also teaching people how to use it from an algorithmic approach to guide your procedures, and also assessing your quality of intervention as well. And the people who are really experienced, they need to understand that maybe what they're seeing is not actually what they're seeing, and maybe there's more pathology there that could potentially allow you to optimize your intervention. So BTK vessels, we know this for a long time, and I think one of the reasons why some of the interventions in the past have failed in the tibial space is because of recoil, but also of chronic undersizing of tibial interventions. And you can see there's this huge difference, especially across the board in the proximal AT, TP trunk, and also the proximal perineal, where there's a big size discrepancy angiographically, almost over 1 millimeter in size with what you see actually by IVUS. And 1 millimeter difference or more, almost 2 millimeters, is a huge difference with regards to, I think, your ultimate outcomes. Now, there's a lot of different technologies out there as well too, but the two primary technologies seen in the IVUS world right now are between phase array systems and rotational systems. And the difference there is that rotational systems do involve a motor drive unit that's a single rotating transducer where you're able to achieve potentially high frequencies. So you can get better imaging, but the issue is you've got this big motor drive unit in your field. Phased array uses a piezoelectric crystals, or a series of them, lower frequency, so lower penetrance, but potentially easier use and potentially improves workflow. So, you can talk to which operator in terms of what they prefer, whether it's quality imaging versus having something that's a lot easier to use. In general, I think we want to try to encourage people to use these technologies and make it part of their workflow and not slow them down. And so this is the reason why different systems are being developed with hybrid features of both phased array and rotational. So you can imagine a system where you could have the power of the rotational system, but not have the motor drive unit in your field of view or on the sterile field, and potentially still also be able to achieve these ultra high frequencies and get excellent depth of penetration. The ultimate depth of penetration, or rather resolution of the near field comes from OCT, but peripheral OCT just really hasn't taken off yet. It has very poor far field. And knowing what's going on in the far field is very important as well when we're doing peripheral interventions, especially depending on what vascular bed we're in. Within the tibials, you need that close-up view, but potentially within the popliteal and the SFA space, especially up in the iliacs, you need to be able to see what's going on well outside of the vessel itself. So if we look at the data, these are several randomized controlled trials that looked at patients randomized to angiography versus IVUS-guided intervention. And you can see that the patients that ended up getting IVUS had freedom from CDTLR that was far superior to that of angiography alone. And most of this was driven by right-sized DCB. So once you put the DCB in, instead of putting in a, say, 5 or 6, maybe you put in a 6 or 7 instead, and potentially allow for appropriate wall contact and delivery of drug into the wall. At least that's one of the theories. And you can see that the patency rates are significantly better as well too. 84% by IVUS versus angiography alone is only 70%. And then also, if we look at another RCT as well too, you can see that restenosis was less when you use IVUS as well in comparison to just angiography alone. Again, same thing, right sizing of DCBs potentially may have been the cause of this as well. But look at the differences in terms of the algorithm, the plan. The number of patients once IVUS was utilized where the plan itself was changed, the treatment length was changed, device size was significantly higher once IVUS was utilized. In addition, if you look at the discordance between angiography versus IVUS, you can see that the reference vessel diameter was different. Almost half of the patients. Lesion length was also different, about half of the patients as well too. And also dissections. That's also another big one as well too. In terms of what angiographically we thought was severe, or less severe, perhaps, than by IVUS was more severe. And that makes sense because most of the time when we do angiography for peripheral interventions, we're just doing a single view. We're not doing an orthogonal view. So what looks fine in one view, the flow can look completely normal, but it's actually a slit. And if you take the orthogonal view, which very few people do, you may see that there's a potentially flow-limited section there that's missed, and that potentially could lead to failure of your intervention. So Dr. Sezemski and colleagues, Eric has spent a lot of time studying this as well too, mining the CMS database, has found multiple opportunities to improve outcomes utilizing IVUS. They looked at over 500,000 Medicare patients who underwent lower extremity interventions from 2016 to 2019, and only about 12% of those patients were treated with IVUS. And they looked at all sites of service as well too, stratified them, CLI versus claudicants, looked at different segments and procedural locations as well. And you can see across the board whether or not, if they use IVUS versus no IVUS, the time to having adverse limb events, ALI, and also major amputation, these were all reduced once you actually utilize IVUS. So they were able to potentially show benefits with IVUS utilization. And so if you summarize the data for this too, looking at all the different studies, case series, so almost 100,000 patients, they were able to kind of give a level 2B rating of evidence for utilization of IVUS. So strong support in the peripheral space. Not the level 1 evidence that we've seen now in the coronaries, but it's a significant improvement over what we had before because people just have not studied it to the same degree. And so you can see also utilizing IVUS, we see a 26% reduction in loss of primary patency, 26% reduction in the risk of major amputation. It is cost effective, so any upfront costs with utilizing IVUS at the beginning of your case, after a year, those costs go away, and potentially there's going to be cost savings as well too, especially if we're reducing those limb events and reducing amputations. So based on this, 15 PAD experts came together answering questions that came up with this consensus document, and you can see that across the board from iliacs, SFAs, and tibials, pretty much complete uniform consistency for tibial intervention, pre, intra, and post-intervention optimization. You should be doing IVUS. Across the board, everyone agrees that upfront and even potentially intra-procedure as well too should be using IVUS as well. So this came out in JSCI, and also multiple societies have rendered their expert opinions as well too, where patients with PAD likely will benefit from utilization of IVUS. So hopefully what I'm proposing to use, develop your own algorithm as well to pre-intervention characterization of what the lesion is. We talked a lot about that on the panel today with this live case. Intra-procedural can help guide what you're going to need to do. Are you subintimal? Are you intraluminal? Did you have good lumen expansion post-ballooning? Could we get away with a DCB, or do we need to put a scaffold in? And ultimately optimize the results of your intervention. Do we need to do additional debulking? Do we need to do something else? Do we appropriately treat the vessel? And ideally also identify dissections. We saw that long length dissection in the proximal portion of the vessel angiographically. We think it's severe. How severe is it? IVUS would be able to tell you that information. So let me show you a quick case. This is a patient, Rutherford 4, diabetes, hypertension, smoker. This is what he looks like. You can see this island of patency just above the pop, and diffuse tibial disease. So ultimately did some below the knee work first to restore 2-vessel runoff. And you can see here, this is going through a long SFA CTO. You see the soft fibrotic plaque here. So you can see I'm intraluminal here, intraluminal, but you can see quickly my wire has gone now subintimal. And so I've re-entered above, and you can see here, this is the chromoflow, this is the true blood flow there. I've actually re-entered well above where I needed to, and there's this long segment of healthy SFA that I could potentially salvage, and essentially we've come back in very close to that profunda. So I really didn't like that. So in this particular situation, I went ahead and used a Pioneer, which is an IVUS-guided reentry catheter, and I was able to go just above the CTO segment into that healthy SFA. You can see my wire shooting across here. You orient the lumen you want to get into to noon, and then that's where you fire your needle, and you can have an adjustable depth here as well. Once I did that, I went ahead and treated the entire vessel with a laser, used a 5mm sculpt, and ultimately ended up using Alluvia in the mid to distal SFA. And then I actually ended up using some tack stents as well too, because there were some dissections as well that we saw in the proximal area where I had created that flap from my errant subintimal re-entry there. So after that, you can see, let's go back in now with IVUS. This is so, I've done a procedure now. I want to see how I did. You can see my Alluvia stent is well expanded, but take a look at that. Angiographically, the flow is normal, and you saw that in my last picture. The flow looked, even though it's not moving, you would appreciate that the flow looked okay. But see this? This is a giant intramural hematoma. So if you're looking straight on this, the lumen looks normal. However, what's happened now is that blood has filled that space in the subintimal channel, and if I had left this alone, the patient would have ended up getting the whole vessel shut down. I ended up trying to treat that with a tack, and that worked pretty well, except there's one spot here which I think you'll appreciate. There's one strut hanging out right here, so that's tack recoil. And perhaps on retrospect, maybe a DES would have been a better choice here too. So I ended up having to treat that area with a short DES. So ultimately, everything ended up looking good, and the patient did very well. So use of IVUS during peripheral interventions has the potential to improve outcomes. There's established benefits during endovascular interventions, and we need more prospective data, real-world data to change the level of evidence. What we have now is expert consensus saying that this is what should be done in the majority of lower extremity arterial procedures. However, we are currently at war with insurance companies and a lot of insurers have tried to fight this. Recently, with the efforts of SIR, Sky, and others, have been able to get Aetna to reverse their original decision regarding reimbursement for some outpatient procedures. But they stopped paying for atherectomy, but they're still paying for IVUS. Hopefully, these efforts will continue to help prove to payers that this is ultimately going to improve outcomes. And ultimately, we want to be able to integrate IVUS into routine practice so that it's not a lot of work for you to do this. It should take seconds to use, allow you to work and continue to do your procedures without any delay, and really ultimately save on cost. Thank you.